Hi everyone, our subject today is hematoma or hemoarthrosis, bleeding in the muscle or joint due to coagulation factor defect. Basics. Homeostasis is a delicate balance between fluidity of the blood so that it can circulate freely within the blood vessels and coagulation so that any breach in continuity of blood vessel can be sealed efficiently and immediately so as not to exsanguinate the body. This delicate balance is maintained mainly by three factors, namely vascular and extravascular tissue, platelets, and plasma factors. Any disturbance in these three factors will lead to either bleeding or excessive clotting, thromboembolism. Platelet versus coagulation type of bleeding. Presence of superficial bleeds like petechia, purpura, small superficial ecchymosis suggest immune thrombocytopenia, vascular cause, or platelet dysfunction. While deep bleeding like muscle hematoma, exsanguinating hematoma, retroperitoneal bleeding, and joint bleeds are pathognomonic of coagulation disorder like hemophilia. History. History should include age and acuity at onset of bleeding, triggers, whether bleeding was immediate or delayed, and whether it was prolonged or exaggerated. Severity of bleeding must be determined, such as nose bleeding requiring cautery or packing or surgery requiring transfusion. It is very important to differentiate bruising due to child abuse. Perinatal history should include detail regarding bruises or petechia, bleeding with circumcision, cephal hematoma, CNS or gastrointestinal bleeding, unexplained anemia or jaundice or bleeding after cord separation. A history of vitamin K administration and maternal drug should be obtained. In adolescent girl, a history of dysfunctional uterine bleeding should be important. A detailed family history should be obtained, including maternal obstetric history of bleeding. For X-linked disorder like hemophilia, a family history of male relatives on maternal side should be solicited and history of consanguinity for autosomal recessive condition like factor 13 deficiency. Medications such as aspirin and other non-steroidal anti-inflammatory drug, anticoagulant, antibiotic, anticonvulsant may be associated with bleeding. The bleeding site may indicate the etiology. Acute mucocutaneous bleeding may indicate immune thrombocytopenic purpura. Generalized bleeding may be associated with the DIC, disseminated intravascular coagulation, vitamin K deficiency, liver disease, or uremia. Mucosal bleeding, petechia, and bruises may indicate disorder of platelet, blood vessel, or von Willebrand disease. Bleeding into soft tissues, muscle, or joint, or excessive bleeding with surgery may be due to deficiency of coagulation factor, hemophilia. Physical examination finding. Children with bleeding disorder are more likely to have large bruises more than 5 cm, palpable bruises, and bruises on more than one body part. Uncommon site for bruises for all ages include the back, buttocks, arm, and abdomen. Finding petechia in the skin and mucous membrane, significance, disorder of platelet number or function, von Willebrand disease or vasculitis. Finding bruises in unusual places, significance, possible platelet disorder or von Willebrand disease. Finding large bruises or palpable bruises, significant coagulation deficiency, severe platelet disorder or von Willebrand disease. Finding delayed wound healing, significant factor 13 deficiency or dysfibrinogenemia. Finding purpura localized to lower body like buttocks, legs, ankles, significant, maybe Henoch-Schönlein purpura. Heart murmur may indicate endocarditis, erythropathy suggestive of hemophilia, joint laxity seen with the Ehlers-Danlos syndrome, and thumb or radial anomaly are seen with Fanconi anemia or thrombocytopenia absent radius syndrome. Hepatosplenomegaly may indicate liver disease. Lymphadenopathy may indicate malignancy. Skin findings include hematoma, petechia, ecchymosis, telangiectasia, purpura, poor wound healing, lax skin, and varicose vein. How to approach the child with the bleeding disorder after performing history and physical examination. Hematoma, as we mentioned, bleeding in the muscle. Hemoarthrosis, bleeding in the joint. Or large ecchymosis. This is deep bleeding. This is coagulation factor defect. Coagulation cascade from factor 12, factor 11, factor 9 with the help of factor 8, factor 10 with the help of factor 5, factor 2, and factor 1. Extrinsic factor with the factor 7. Intrinsic pathway factor 12, 11, 9, and 10 will be measured by PTT, and PT will measure factor 7. TT will measure the last step of the coagulation, conversion of factor 2 to factor 1 from fibrinogen to fibrin. Differential diagnosis. PTT normal, as we mentioned, if PTT and PT normal, differential diagnosis could be factor 13 deficiency, alpha-2 antiplasmin deficiency, and oral anticoagulant. If the PT prolonged and PTT normal, if the PT prolonged, factor 7 and the common pathway prolonged, and the PT normal, differential diagnosis, of course, factor 7 deficiency and oral anticoagulant. If PT normal and PTT prolonged, if PT normal and PTT prolonged, defect in these factors, could be heparin induced. Patient may need mixing study. If the result of mixing the study corrected, this could be hemophilia or von Willebrand disease. As we mentioned, hemophilia 8, factor 8 deficiency, hemophilia B, factor 9, and hemophilia C, factor 11, all will measure by PTT. Or von Willebrand will affect factor 8 function, and there will be correction. If it does not corrected with the mixing study, this could be lupus-like anticoagulant, factor inhibitor, Bethesda assay. If PT and PTT prolonged, if both of these are prolonged, patient need thrombin time, TT. It will be prolonged in liver disease, so we'll measure fibrinogen, factor 2. If it is reduced, this is afibrinogenemia or DIC. If it is normal factor 2 level, this is either dysfibrinogenemia or heparin. If it is normal TT, if it is normal result, also could be liver disease, vitamin K deficiency, warfarin, early DIC, circulating anticoagulant, dysprothrombemia, vitamin K deficiency and warfarin overdose, factor affected 10, 9, 7, and 2. These factors will be affected, so of course will be elevation in PTT and PT. Correction study. When a PTT is prolonged, 1 ml of a plasma patient plus 1 ml of pooled controlled plasma. If there is no correction, worsening on incubation, this is mean presence of inhibitor. If there is more than 50% correction, factor like 12, 11, 9, and 8 deficiency should be suspected. If there is no bleeding, this is factor 12 deficiency. If correction with the adds of plasma, this is factor 9 deficiency. If the correction with the age serum, this is factor 8 deficiency. If no correction with the aged plasma and the old serum, aged serum, this is factor 11 deficiency. Clinical peers. Never do bleeding time, BT, and clotting time, CT, as screening test. always do following test: complete blood count with the platelet count and peripheral smear for platelet morphology. PT and PTT, TT, and serum fibrinogen. Alert: PFA 100, low specificity and sensitivity, affected by medication like nonsteroidal, not recommended as a screening test. Bleeding time, prolonged when platelet count less than 100,000, affected by medication like aspirin and nonsteroidal and antihistamine, does not correlate with the bleeding risk, highly operator dependent, not recommended as a screening test. PT and PTT, normal range are age dependent, so be careful. Polycythemia, hematocrit 65 or more, underfilling of the specimen tube may result in spuriously prolonged result. Heparin contamination result in a spuriously prolonged result. Von Willebrand disease study, value fluctuate over time and may be periodically normal in affected individual. May require repeated testing to make the diagnosis. Thrombin time, measure the last step in the clotting cascade, the conversion of fibrinogen to fibrin, as we mentioned in the diagram. Thrombin time is prolonged when fibrinogen levels are low, hypofibrogenemia or afibrogenemia, with the dysfunctional fibrinogen, dysfibrinogenemia, or due to factors which interfere with the fibrin formation, like heparin, fibrin split product. Congenital afibrogenemia is a rare disorder. Although the blood is incoagulable, hemorrhage is rarely spontaneous and usually occur with the trauma or surgery. Vitamin K deficiency is a common in neonate, malnourished child, those received a broad-spectrum antibiotic, and children with the cholestatic liver disease. Hemorrhagic disease of a newborn is rarely seen anymore because of prophylactic administration of vitamin K in the newborn nursery. Vitamin K deficiency may present as a generalized bleeding into the skin, gastrointestinal tract, and central nervous system. Dicarbomural and rat poisoning, superwarfarin, also act by affecting vitamin K and therefore also vitamin K dependent factor 2, 7, 9, and 10. Inhibitors. Inhibitors may be directed against a specific coagulation factor or reaction site in the coagulation pathway. Inhibitors against specific factors usually affect factor 8, factor 9, factor 11, causing prolonged PTT with normal PT. Lupus anticoagulant is directed against a reaction site and causes prolonged PT and PTT. It is more likely to cause thrombosis than bleeding. Hemophilia. Deficiency of factor 8 is hemophilia A, and that of factor 9 is hemophilia B or Christmas disease. These are transmitted as X-linked triad. Therefore, family history of bleeding in male in the mother's family should be obtained. Hemophilia A or B usually as bleeding into the muscle or joint and easy bruises. Because factor 8 does not cross the placenta, bleeding may occur during the neonatal period. Factor 11 deficiency or hemophilia C has autosomal recessive transmission and milder symptom than A and B. Factor 12 or Higman factor deficiency causes prolonged PTT, but it's usually asymptomatic. Von Willebrand disease. Von Willebrand factor function to inhibit platelet function to bind platelet to collagen, facilitate the platelet block formation, and protect factor 8 from degradation, extended its half-life. Type 1 von Willebrand is the most common type and has a clinical incidence of 1 in 1,000. The most common cause of lifelong symptom of mucocutaneous bleeding due to deficiency of von Willebrand factor. Inheritance is typically autosomal dominant. PTT and bleeding time are often, but not always, abnormal, and so screening for von Willebrand factor should always be considered when evaluating bleeding disorder. The PTT corrected with 1-to-1 mixing with the pooled plasma. In addition, stress, medication, trauma, difficult vinipicture may increase von Willebrand level. Level of von Willebrand factor are dependent on blood type and may be influenced by the age. Interpretation of tests require a qualified laboratory and often assistance of the hematologist. This is type of von Willebrand disease and the lab result. Von Willebrand antigen, von Willebrand ristosine cofactor, factor 8 level, and von Willebrand multimer analysis. Type 1, Type 2A, Type 2B, Type 2N, Type 2N, and Type 3. Of course, as we mentioned, Type 1 is the most common. Disseminated intravascular coagulation, DIC, is a generalized consumption of clotting factor, anticoagulant protein, and platelet. It is usually triggered by the severe illness, hypoxia, acidosis, tissue necrosis, and endothelial damage, and may be accompanied by shock. It may appear as a hemorrhagic or thrombotic disorder or both. Liver failure affect all coagulation factors except factor 8. In both DIC and liver failure, there is prolonged PT, PTT, and TT thrombin time and decreased fibrinogen. Fibrin degradation products are elevated in DIC and are normal or elevated in liver failure. Platelets are decreased in DIC but may be normal or decreased in liver failure. Factor 13 deficiency often present in infancy as bleeding after separation of the umbilical stem and later as intracranial, gastrointestinal, and intra-articular bleeding. Result of routine coagulation study are normal. Thank you for your listening.